Thank you very much for the invitation and the opportunity to present to you all today. I'm Ryan Cassaday from the University of Washington and Fred Hutchinson Cancer Center in Seattle, and I'm going to be covering our current approaches for adults with T-cell acute lymphoblastic leukemia. I'm going to cover a few different topics in this talk. First, discussing some of the risk features that are unique to TALL in adults, and then I'll go through some recent data where new agents have been incorporated into the frontline treatment for these patients. I'll then summarize some of the strategies that are being studied in relapsed and refractory T-cell ALL, and then I'll also touch on the current state of immunotherapy strategies that are being studied for this disease. So I'll start with risk stratification of T-cell ALL in adults, and I think in 2026, the most important subgroup with which you should be familiar is the early thymic precursor, or ETP subtype. There have been multiple studies, some of which I'll show in a minute, that suggest an inferior prognosis for these patients. This disease is identified by its distinct immunophenotype. The cells express CD3, which is typical of T lineage leukemias. They lack CD1A and CD8. They have weak or absent CD5 expression, and they also co-express stem cell or myeloid markers, which can sometimes make it challenging to distinguish between so-called mixed phenotype acute leukemia or undifferentiated leukemias and things of this nature. So speaking to the immature nature of these T cells when they become malignant. But unfortunately, while it's fairly well characterized, we do not yet know the optimal treatment approach for these patients, in my opinion. Studies in children have shown a clear worse outcome. This is one of the first studies looking specifically at outcomes for ETP ALL. This was a study retrospectively performed by investigators at St. Jude in the USA and the AEIOP cooperative group in Europe. The blue curves are those with the ETP ALLs, and you can clearly see in both these different organizations much worse survival, much higher incidence of relapse for the ETP ALL patients with these different strategies. We've also seen that the outcomes are quite a bit worse in the MD Anderson experience, which is shown here. Most of these patients were treated with some form of hyper-CVAD-based therapy. Transplant was not routinely being used for these patients, but nonetheless, you can clearly see the blue curve here showing much worse outcomes. This begs the question, what is the role of transplantation for this disease? Can that overcome some of the adverse outcomes that we see? And at least based on this retrospective analysis from a French cooperative group, I think there's fairly compelling data. It may not be statistically significant, but for the patients with ETP ALL who were lucky enough to undergo stem cell transplantation, that's the dashed blue line here, the outcomes were markedly better than those who did not get a transplant. And it's sort of easy to point to that and say, well, I mean, transplant itself is a predictor of better outcome. You're more fit, you're younger, you have better social support. And if you look at this curve here, that's what I would predict you might expect to see in terms of an advantage, particularly with a disease like T-cell ALL. Like if you're able to get a transplant, yeah, your outcome's going to be a bit better, but I would not expect it to have that big of an impact. So I suspect there's probably a real signal here, small number of patients, it's a retrospective analysis, but this has informed my practice quite a bit. In terms of looking for molecular or genetic features that can risk stratify patients, I think the French cooperative group GRELAL has done most of the work here. One of their first studies was looking at a large prospective clinical trial where samples were analyzed for specific genetic features, and they were able to identify two different oncogenetic classifiers. They dubbed their low-risk classifier as patients who had either mutations in Notch1 or FBXW7 and did not have mutations in NRAS, KRAS, or PTEN. So if you met those criteria, you were considered low risk. But if you had any other combination of features, you were considered high risk, and that's the yellow curve here. So pretty clear prognostic signal here with better outcomes for the patients who are low risk. They have since refined this a bit and also did a comparison to a comparable cohort of children with T-cell ALL. So this study looked at the incidence and prognostic impact of 72 different genes that were analyzed by next-generation sequencing. They first identified abnormalities in their adult cohort and then validated them in their pediatric cohort. which was a useful way to confirm the importance of their findings. And in a similar manner, they identified two different risk groups that have a admittedly somewhat complicated application. So low risk patients had to meet both of these criteria. They must have a mutation in Notch1 FBXW7, same as before, or EP300 or PHF6. So those two new genes were added to the mutations that had to be present. They also could not have mutations in some of the same genes as before, like NRAS and KRAS, but also mutations in the PI3 kinase pathway, IKZF1, TP53, IDH, DNMT3A. So you could not have any of those mutations and must have had one of the mutations on the top line. Similar, high-risk patients were everybody else. So if you didn't have one of those favorable risk mutations, or you had like mutations in both categories or whatever, you were considered high risk. And you can see on the curve here, the red line are those that have the high risk NGS classifier. Importantly, this was independent of either white blood cell count or MRD status. So this retains significance even in the presence of those other risk factors. But admittedly, it's unclear how to use this to guide treatment. We don't really know, for example, is it better to refer these patients for transplant, or is it better to use a particular treatment approach? We just know that they don't do as well with these particular strategies. Switching gears now to treatment and efforts to optimize our frontline approach for T-cell ALL. Admittedly, there have not been great studies in adults in several years for this entity, but there have been some clues from pediatric clinical trials for T-cell ALL. The first trial I want to mention is the COG-AALL-0434, which was a randomized study looking at two different questions: the preferred interim maintenance regimen to use, and then the role of nelarabine. So it was a 2x2 pseudo-factorial randomization that occurred after patients got induction therapy. So they at least had to get through induction. And then they were randomized to two different interim maintenance arms, one of which was the traditional Kapitzi-style methotrexate with pegaspargase and vincristine. The other randomization, or the other arm, excuse me, for that randomization was a high-dose methotrexate-based interim maintenance. The second randomization was the addition of 6 5-day courses of nelarabine versus no nelarabine. So that led to 4 different treatment arms on this clinical trial. The key results are as described here. So the primary endpoint of this trial was disease-free survival. Indeed, nelarabine did improve this outcome to a statistically significant degree, but the absolute benefit was only 6%. And in terms of the interim maintenance randomization, the Kapitzi-style methotrexate led to significantly better results. Again, not a huge numerical difference, but statistically better than high-dose methotrexate. Importantly, the overall survival was also better with the Kapitzi-style methotrexate, but it was not better with the addition of nelarabine. And in summary, then, if you look at the disease-free survival of the arm that had the best results, so got the better of both of those two strategies, Kapitzi-style methotrexate and nelarabine, 91% at 5 years. So very, very good outcomes for these patients. What I think actually was maybe the most interesting and practical finding, though, from this clinical trial was patients that were randomized to nelarabine had very, very few CNS relapses. And if you actually look at the numerically, the 5-year cumulative incidence of CNS relapse for these patients with T-cell ALL, it was less than 2% for the arm that got nelarabine, and it was closer to 7% for those who did not. But admittedly, these are still fairly rare events. I mean, the y-axis on this scale makes the difference look a lot bigger on the figure. But it certainly looks compelling that nelarabine will reduce the frequency of these events, even though the total incidence is fairly low. The second clinical trial I want to talk about is the AALL-1231 study. So this was a subsequent trial that the COG did, now asking a question about the role of bortezomib and the role of cranial radiation as part of prophylaxis. So they randomized patients to either receive bortezomib or not during induction and delayed intensification. So that was the one randomization that occurred on this trial. But then for patients who were deemed low and intermediate risk, they were assigned to not receive prophylactic cranial radiation therapy as their CNS prophylaxis. So essentially what that means is for patients who were very high risk, that included people that had a poor response to their induction therapy and patients who also had persistent MRD at a high level and consolidation. But interestingly, this designation wasn't defined by their CNS status at presentation. So basically, you had to have somewhat chemotherapy refractory disease at systemic sites uh, to be to still fall into the cranial radiation arm. If you had very chemotherapy sensitive sites, you were assigned to not get prophylactic radiation. So the primary outcome for the trial was event-free survival. And in terms of the key finding for the randomization of bortezomib, that did not significantly improve outcomes. There was a slight numerical advantage, but it was not statistically significant. But interestingly, the subgroup of patients with T lymphoblastic lymphoma, so more extramedullary disease at presentation, those patients actually did better with bortezomib. And despite only 9% of patients on this trial getting cranial radiation, the event-free and overall survival overall was comparable to the AALL0434, the study I showed on the last slide, where patients were almost uniformly given cranial radiation. So it appears that you can be more selective in the use of cranial radiation, particularly for patients who have a very good response to systemic therapy. Now, another interesting observation from this trial is the rates of death in remission with this approach were significantly higher than what was seen with the precursor study 0434. Now, that doesn't appear to just be because of bortezomib. So if you look at the adverse event rates among the patients who got bortezomib versus those who did not, the rates were comparable. There were other modifications made to this trial. So, for example, dexamethasone was the steroid used in induction. They got more pegaspargase. So those may have contributed to the poor outcomes, or the higher incidence of death. The types of fatal events that occurred on this trial more frequently were things like infection, thrombosis, multi-organ failure. But again, on the whole, these are still very infrequent events. While it is discouraging to see that frequent death and remission, particularly in children and young adults, these are still fairly unusual events. So, but it is an important consideration if you're going to explore some of these strategies, particularly in not so young adults. Now, with those two studies described, investigators from the Children's Oncology Group actually have looked specifically at subgroups of young adults that were treated on these trials to see whether or not these different interventions helped. And these data were presented at ASH a few years ago. Just as a summary, the two trials in question here are the 0434 trial, that's the Kapizzi methotrexate versus high-dose methotrexate randomization, and then the nelarabine versus not. And then the 1231 study, which was the bortezomib randomization, and then being assigned to skip cranial radiation if you had a really good response to systemic therapy. It's important to note that the standard arm of 0434, so that's the Kapizzi methotrexate and no nelarabine, is essentially identical to what the C10403 regimen that a lot of us use for young adults with ALL had. So you can sort of extrapolate the results there in terms of the chemotherapy regimen being used. And here were the comparisons. And the left side here, just to take a moment, the curves here on the top are the two arms who got the Kapizzi methotrexate, the preferred interim maintenance. In the comparison of the black solid curve and the red dashed curve, that's nelarabine versus no nelarabine among that preferred interim maintenance. So you can see no real difference there. Kind of a similar story for the high-dose methotrexate interim maintenance. Again, that was the less preferred option for that randomized question, but the addition of nelarabine also didn't seem to help. On the right are the subgroup of young adults with ALL who got bortezomib versus not. Similar story. You don't really see an advantage with adding bortezomib for young adults. So really, if you try to extrapolate the COG experience for nelarabine and or bortezomib into an adult practice, there doesn't appear to be a whole lot of advantage of adding either drug in these settings. Well, what about nelarabine in hyper-CVAD? So that has been explored at MD Anderson. There have been ongoing studies of this combination with different iterations and so forth. One of the earlier descriptions is shown here. The red curves on these plots are the arms that got the nelarabine, and the blue curves were those who just got hyper-CVAD. So really no clear advantage with the nelarabine, and frankly, if anything, giving nelarabine in the lymphoblastic lymphoma patients seemingly led to worse outcomes. Initially, when this study was reported, there was possibly a benefit for the ETP subtype, which was certainly encouraging since those patients don't do as well. But unfortunately, when they did a longer-term follow-up, what benefit was present seemed to be restricted to those who were non-ETP. So again, it makes it hard to really reliably conclude anything about the role of nelarabine in this setting. And what about venetoclax, an agent that has gained a lot of steam, particularly in T-cell ALL? This was a frontline study done at the Dana-Farber and at MD Anderson. Included newly diagnosed and relapsed refractory ALL, looking at the mini hyper CVD combination plus venetoclax. So importantly, this is a heterogeneous population, some B cell, some T cell, relapsed and refractory as well as newly diagnosed. They looked at 2 different venetoclax dose levels with a 6-day ramp up. They ultimately settled on 600 milligrams daily for a 21-day cycle as the preferred regimen. Among the newly diagnosed patients specifically, 10 out of 11 were able to achieve an MRD negative remission, and the disease-free survival was quite good at 2 years. But again, this is a fairly small subgroup of patients. Among the relapsed refractory patients treated in this study, only 3 out of 8 got into a complete remission, so obviously not as encouraging. And from a practical standpoint, at least as of last year, when these data came out, neither FDA nor NCCN are backing the use of venetoclax in this setting. So it is potentially practically difficult to use this in T-cell ALL where it doesn't have these regulatory and guideline level recommendations. So to summarize, the efforts to date trying to incorporate new agents into frontline T-cell ALL, nelarabine did improve the 5-year disease-free survival on the 0434 study, including a significant reduction in CNS relapses. That's great. Admittedly, though, the benefit appears restricted to children and not adolescents and young adults. But that significant CNS relapse advantage could potentially be an important feature clinically when thinking about some of these patients. It is pretty hard for me to appreciate what benefit comes from adding nelarabine to hyper-CVAD. The non-randomized comparisons that have been done include patients treated in different eras. Some of the ETP patients may have been getting more transplants as time went on and so forth. In my practice, though, I'll consider adding nelarabine to hyper-CVAD in a manner similar to what was studied at MD Anderson if I think they're at a high risk of CNS relapse, again, kind of leveraging that children's oncology group experience. In terms of these other agents, bortezomib seems to mostly help children with lymphoblastic lymphoma. That's not really a patient population I treat. The data don't appear to bear out very strongly in young adults. And certainly the early data with venetoclax are encouraging, but considering the limited studies available and the heterogeneous population studied, I think it's a little bit hard to make it a standard. Now for relapsed refractory T-cell ALL, this is a particularly challenging disease to treat. There have been efforts to identify new agents for this disease, and they have not gone very smoothly. This was the study that got nelarabine approved, but really the outcomes are quite poor. The CR rate's only 30%. Survival is quite poor. Most patients relapse within a year. You can see this is the time from start of complete remission in weeks, where remission is lost for almost everybody by 60 weeks, with only a few lucky folks surviving longer. Vincristine sulfate liposome injection was available for many years. This has been pulled from the market. It's no longer available to my knowledge. Similarly poor, relatively poor results. There'll be occasional good responses with this, but this drug is no longer available. But really since then, there have been very limited efforts to try to get new agents in T-cell ALL. One strategy that I will sometimes consider borrowing from our pediatricians again is the ALL-R3 regimen. So this was a study that included over 200 children, so up to age 18, in first relapse. It was a randomized study looking at either idarubicin or mitoxantrone during induction. So that was the only difference between the 2 arms. The remainder of the treatment was the same. It's pretty similar to a COG-based pediatric regimen. It is not for the faint of heart. It is a complicated regimen. It's fairly intense. And it's analogous to treating, patients with pediatric-inspired therapy. So if you're familiar with that, you'll be familiar with some of the concepts here. But interestingly, changing only that one drug was able to yield significantly better overall survival. I think this is progression-free survival here on the bottom. So you can see the blue arm are those who got mitoxantrone in induction, and everything else was the same after that. Relatively good outcomes. And this held up. I mean, the subgroups are fairly small. There was only 24 patients with T-cell ALL treated in this trial, but there did appear to be a significant advantage with the mitoxantrone arm here as well. So, Really to my knowledge in T-cell ALL in particular, these are arguably the best results we've seen with any option. So I will try to leverage this when possible, particularly in a young adult who wants to be aggressive. When you look, however, at the NCCN guidelines for options for relapse refractory T-cell ALL, unfortunately, it does not provide very practical guidance. When you see this number of options that are recommended, that usually indicates that we don't really know what's best. So some observations aside from that, the only preferred option is a clinical trial, which again speaks to the lack of knowledge we have about this entity. The only agent that has specific regulatory approval for this indication is nelarabine, so that's right here. But there's all these other options that are considered, again, based largely on small single center, level data. And I think generally, given the poor outcomes for patients in this situation, I think things like toxicity and cost have to be considered. Unfortunately, the likelihood of cure in this situation is fairly small. So the harm we do to patients has to be considered in this situation in particular. One approach that I've started to include more frequently is combining nelarabine with other chemotherapy agents. It might improve the outcomes, but it can also increase the toxicity. So this was a retrospective comparison of two different strategies, primarily at the Dana-Farber Cancer Institute, where single agent nelarabine, that's the mono arm here, versus combo, which were various combinations, but the most common combination used was adding cyclophosphamide and etoposide, sometimes referred to as the nectar regimen. The combo arm had more grade 3 or 4 adverse events, including things you would expect from the addition of cyclophosphamide and etoposide, cytopenias, and infections. There were no significant differences in the rates of complete remission or MRD negativity, despite the addition of these other chemotherapy agents, but obviously the survival looked better. There were no differences in the rates of subsequent transplant, the number of cycles, et cetera. So it raises some questions. Is this just a reflection of selection bias? The patients that we think can tolerate the more intense regimen got that and thus did better just because they were more fit or something. It's a little unclear with a design like this. What about venetoclax? Again, the experience here is fairly limited. It's mostly data from MD Anderson. A small retrospective analysis here of 12 patients that had T-cell ALL5 given different chemotherapy backbones with venetoclax, and you can see some results here. They've also looked specifically at mini hyper-CVD plus ven, but again, only a small subgroup of these had T-cell ALL, and those patients also got nelarabine and pegaspargase, so it's a bit hard to know how effective this combination is. So my interpretation of all these data, for a young adult in first relapse, I'll usually prefer the R3 regimen. I think it arguably yields the best available options, and it provides a built-in strategy to get those patients to transplant if that's the goal. It also includes a strategy that avoids transplant if that's your goal. I'll try to add etoposide and cyclophosphamide to nelarabine in patients who I think can tolerate the greater risk of toxicity. I honestly rarely use venetoclax in my practice. I generally will only do it in patients that have seen multiple prior lines of therapy that remain really motivated. I think there's some logistical administrative issues that come up with this regimen that have to be considered. I will certainly offer and refer for clinical trials whenever feasible, though, again, given the poor outcomes and hope for better options in the future. Which leads into one of my last points, which is talking about immunotherapy options for T-cell ALL, which are sorely lacking for several obvious reasons. When we think about B-cell targeting agents like CAR T-cells and blinatumomab and so forth that lead to B-cell aplasia, that's certainly a clinical concern, but there's not as much risk of that. If you think about that in a patient getting a T-cell directed therapy, that's essentially causing AIDS for the time that the T-cell depletion is active, which is obviously very concerning in terms of side effects and risks. There's also a concern of something called fratricide, where the effector T-cells that you're trying to induce to kill your T-cell ALL might also kill other effector T-cells, so they're sort of killing themselves or killing their brother in a sense, which is where fratricide comes from. The other issue is this is a really rare disease. It's only 20% approximately of ALL, so it's hard to do clinical trials when you think about how rare this is. There are ongoing studies looking at different CAR T-cell strategies for T-cell neoplasms. I've highlighted several here that have at least published some data or appear fairly promising. Arguably the largest experience to date is with the WuCart 007 product, which is in ongoing phase 2 trials currently. Daratumumab, the drug we use routinely in myeloma now, is being studied specifically for patients who have MRD after chemotherapy in a U.S. cooperative group trial. And I am not aware of any mature efforts to produce a bispecific agent for T-cell ALL, like a blinatumomab essentially for T-cell ALL. They may be being explored somewhere. I'm just not aware of any mature efforts. So in conclusion, ETP ALL, which is a high-risk subtype of T-ALL, can be identified by flow cytometry. NGS-based methods can also identify high-risk prognostic features. Nelarabine, when added to frontline chemotherapy, does improve disease-free survival in children, but seemingly not young adults with T-cell ALL, and it may also reduce the risk of CNS relapse. Our options for relapse refractory T-cell ALL are very limited, so I would encourage participation in clinical trials whenever possible for these patients. And there are various ongoing immunotherapy strategies being explored, but unfortunately, we're probably still at least a year or more out from any approvals for these strategies. So more to come, hopefully, in the years ahead.